So my task today is to talk about laser selection for HoLEP, and this first slides show us what is the evolution of lasers since 1995, when the first low-power Holmium laser appears on the scene and was introduced into the clinical practice. Three different lasers appear on the scene. So the diode low power, and the Thulium laser low power, continuous wave, and the green light lasers. And more recently, we have witnessed new technical developments with the arrival of new laser with a high power and the possibility to modulate the pulse. And between AUA and EAU, we have already seen that there are no big differences. For both of them, HoLEP is one of the option for treatment of symptomatic BPH, but there's a little difference in EAU guidelines because it's mainly suggested as first treatment option, especially for large prostate size. And I disagree a little bit with that because, in my opinion, HoLEP should be considered the new gold standard for BPH in surgery, at least for those patients who require or deserve a radical treatment. And this is not because just my opinion. I do perform up to 500 procedures per year since more than 10 years, but because we already have high quality evidence in literature, and it's a versatile laser. We can treat both BPH and stones. It fits with all prostate sizes that we already have seen, and fits with all the techniques. We can perform 3-lobe, 2-lobe, and block, and whatever. And we can also perform ejaculation sparing technique. And we can modulate with the new lasers the power. We can use high power if we have a hard tissue. We already have seen how tissue may change the procedures. And we can use, in case of a hard tissue, sclerotic tissue, high power. And we can slow down to low power in some areas, such the complex apex sphincters. And we can also use the pulse modulation system, which has been introduced recently. And this can help us to have a better hemostasis. But how do we choose the right laser for the technique? Because several manufacturers are available now on the market, and each produce its own Holmium laser. So as we can see in this slide, we have several different lasers. We have the Pulse 120, the Cyber Holmium 150, the Multipulse, Megapulse, and the Empower H100. But all of them are pretty comparable. They are all at the same wavelength, obviously. They may develop low power up to high power. Basically, are very large and heavy machine, and let me tell you, are very fragile machines. So we have to take into account that if we have to move the laser from an operating room to another operating room, sometimes it has to go in an elevator. It's a matter. It can break very easily, and all of them use a dedicated plug of a 32 ampere. And this is very important to know. So, more than technical features, the selection should rely on personal preference and experience. As I said, not only technical differences between lasers, but the cost of the laser may vary. Not only related to the number of procedures that we perform per year, but also the availability of reusable or disposable fibers or dedicated fibers. In case of a pulse modulation system, has the virtual basket or the Moses effect, we have to use dedicated fibers, and this transfer in a higher cost. And finally, and fortunately, the new laser a little bit less noisy, because the first lasers were very noisy. And a point that I want to stress out a little bit is the need and availability of an effective assistance service. So as I said before, these machines are very fragile. So a backup service is very important. If I have to choose a laser, of course I want to have the pulse modulation system, no matter if you use the Moses, the virtual basket, or whatever it is. But as we all know, the two peaks technology, the first one who separates the waters, creating a bubble, and the second one who delivers the laser energy straight to the targets, translating to increased efficacy and high precision and optimal energy delivery. And does Moses technology enhance the efficacy and the outcome of standard HoLEP? This meta-analysis shows yes. So if we consider all the intraoperative hemostasis time, the enucleation time, the operative time, Moses performs better compared to traditional HoLEP. This is the setting that I personally use. I prefer to use low power for both cutting and coagulation. Of course, with the coagulation, I prefer to use a long width pulse. And this is intermittently associated with the gentle mechanical anatomical dissection. I don't like to use a lot of energy. I think that the more energy you use, the more irritative symptoms you will have at the end of the procedures, so postoperatively. And in these two very short video, I want to ask to the audience if anybody is able to understand what laser I'm using. So I think both of the procedures are exactly comparable. If we find a nice enucleation plane, no difference between the pulse Moses or the cyber Holmium with the virtual basket, nor intraoperatively or postoperatively. That's in my opinion. So what is true nowadays is that the trend of the manufacturers is towards pulsed system. And that's why the new Thulium fibers or the true pulse Thulium are on the market. And so that's one of the reasons why I don't like to talk about HoLEP, MoLEP, TULEP, whatever it is. I just like to talk about prostate enucleation, endoscopic enucleation. And of course, we have now literature comparing MoLEP and Thulium, and no big differences between the two techniques, but the surgical times. And these may be mainly related to the achievement of better hemostasis during the procedures, which obviously translate in a shorter operative time. And this is also the new Thulium laser on the market. It goes from the continuous wave to a real pulse laser with the possibility to have to plug the laser in a simple plug, no needs any longer of a 32 ampere. And in this case, I will show you just two short video comparing the pulse Moses with the real pulse Thulium. You will see again that we have in both cases a nice anatomical plane. You will see the typical little brown of the Thulium laser, which translate, in my opinion, to a better hemostasis, not only during the procedures, but a lasting hemostasis after the procedure. And so in conclusion, Holmium laser selection depends on several factors, especially surgeon preferences, endoscopic experience, economic resources, and availability of assistant service. If possible, I would choose high-power lasers with a pulse modulation, since this technology has shown to improve intraoperative outcomes. And the Holmium is still competitive with the new Thulium pulsed lasers. No significant differences up to date, but literature, I think, is still premature because, as I said, the hemostasis appears to be better with the new Thulium. Thanks a lot for your attention.